Hello class, I just want to go over week 6 day 2 lesson that we missed because of the Thanksgiving holiday. Our concept is mobility and our exemplar is normal versus abnormal mobility. And what I'd like you to do is to look through Appendix 43. We would have normally done this activity in class, where we look at the physiological consequences of what mobility does on all the body symptoms. And the first one that we would start with is the integumentary system. And the changes that we would see would be increased pressure on the skin, which is aggravated by metabolic changes, and of course decreased circulation to tissues, causing ischemia, which can then lead to pressure ulcers. We've discussed that in the past, and so many of our other concepts, we've kind of interspersed this concept of mobility because we have seen the unfortunate consequences of what immobility can do to our patients when they're not moving very well. The next body system is respiratory, and with decreased mobility or immobility, decreased respiratory movements can lead to decreased oxygenation and carbon dioxide exchange. Without that good effort and good inspiratory volume, it really can affect the diffusion of gases, thus making our patients somewhat hypoxic. And of course, being immobile will also cause stasis of secretions and weakened muscles, resulting in atelectasis and hypostatic pneumonia. And as people lay around and become immobile, there is a decreased cough response. The effect on the cardiovascular system is orthostatic hypotension, which causes less fluid in the circulatory system, stasis of blood in the legs, diminished autonomic response, decreased cardiac output leading to poor cardiac effectiveness, which results in increased cardiac workload, increased oxygen requirement, and of course these people who lay around, which we've talked about with the concept of perfusion, leads to an increased risk of thrombus formation or the increased risk of a DVT forming. Metabolically has quite a significant impact with immobility. There is an altered endocrine system which can affect a lot of the inhibition or secretion of the hormones. We will be talking about specifically this week on day 2 regarding the function of the thyroid gland, thus looking at the problems of hypo and hypothyroidism. When people are laying around, there is definitely a decreased metabolic rate. There are changes in protein, carbohydrate, and fat metabolism, decreased appetite with altered nutritional intake. If you go back when we talked about problems with protein, there can be a negative nitrogen balance, which causes a lot of muscle loss, decreased protein intake, resulting in obviously your patients losing a lot of that muscle tone as well as muscle mass. Loss of weight, alterations in calcium, fluid, and electrolytes, reabsorption of calcium from bones, and decreased urinary elimination of calcium, resulting in hypercalcemia. Elimination, including both urinary and bowel function. There is a chance of urinary stasis, reabsorption of calcium resulting in renal calculi, decreased fluid intake, poor perineal care, and indwelling catheter resulting in increased risk of urinary tract infections. With the bowel, obviously decreased peristalsis, leading to constipation, and a very serious consequence of that constipation can be fecal impaction. The next system is the musculoskeletal, where we've kind of touched upon that with decreased muscle strength and mass, causing atrophy of those muscles, I was always taught when I was in nursing school that what you don't use, you lose, and when people are immobile and lay around, that muscle starts to atrophy or get smaller and weak. Impaired balance and stability, causing your patients to develop osteoporosis, fractures, foot drop, and definitely altered joint mobility. There can be some neurological and psychological problems, changes in emotional status, depression, alterations in self-concept, patients more anxious just laying around, behavioral changes that we may see with our patients who become immobile can lead to withdrawal, altered sleep-wake patterns, hostility, and sometimes inappropriate laughing or passivity. So some very, very significant changes can take place when people are immobile or really have less motor function. As far as developmental changes that we see when our young children are immobile, can lead to slower progression of motor skills and intellectual and musculoskeletal development, body aligned with gravity resulting in unbalanced posture. Children who are immobile can be socially isolated, and it can also delay their development of independence. In the adult, changes in development because of mobility can lead to alterations in family and social systems and alterations in job identity. And as the person begins to age, we see alterations in balance resulting in major risks for falls and injuries. There can be a steady loss of bone mass resulting in weakened bones, decreased coordination, and slower walk with smaller steps, alterations in functional status, and of course, with immobility can lead to obviously an increased dependence on staff and family. So that's just what we would have gone over with Appendix 43, kind of talking about that exemplar of normal versus abnormal mobility. With our concept of mobility, our other exemplar this day is osteoarthritis. And I just want to kind of go over the PowerPoint with you to make sure that you're aware of the important highlights regarding this exemplar. Osteoarthritis is one of the most common forms of arthritis. It develops as wear and tear on joints and break down cartilage. Many times because of that cartilage wearing away that kind of cushions bone to bone, that begins to wear away, and then patients begin to experience a lot of pain because now they're having bone on bone. And that's where the pain comes in to be, and the locations of where this can happen most frequently is in the hands, in the knees, and in the hips. It is a degenerative joint disease. It can be localized, generalized, or idiopathic. Not quite sure why this happens, but it is a progression, erosion of the joint articular cartilage, and with that, bone spurs can actually develop. It can be primary or idiopathic. There's not a single clear cause. It can be secondary arthritis to some kind of primary problem that the person is having. Maybe it's due to some past trauma, bone disease, or even some inflammatory joint disease. It is an idiopathic osteoarthritis that's associated with age, and excessive weight contributes to osteoarthritis. That's why it's really important that as people begin to age that they do maintain ideal body weight, participate in moderate exercise program. Inactivity and excessive exercise can lead to premature degeneration of those cartilages, causing more of that bone on bone. Onset of osteoarthritis is usually gradual, very insidious. What begins to happen is pain develops along with real serious stiffness in one or more joints, and the pain can be referred to other parts of the body. Presentation of osteoarthritis in older patients can again present joint pain, degeneration, and with that pain and degeneration you might see an unsteadiness in their gait and in their walking, which causes one to be more increased risk for falling. There's no treatment available to stop the progression, but early treatment is beneficial, and we try to help people find the resources to be able to live with osteoarthritis because it is a chronic condition and a chronic disease. First, we start off with those non-pharmacological therapies, educate, teach patients about weight reduction, exercise, and to get specific rest at certain rest intervals to hopefully reduce some of the discomfort that comes with osteoarthritis. Some of the non-pharmacological therapies, when it gets so bad that there is an unsteadiness in their gait, we highly encourage the use of canes and crutches and walkers to prevent the risk of falling and having some serious issue happen because of that. Use of assistive technology helps with functional ability. Sometimes with the pain, it helps to use heat versus cold applications to reduce a lot of the pain and the swelling in those particular areas. Sometimes physical therapy and rehabilitation are another great way in which to help keep those joints mobile, as well as to help reduce a lot of the discomfort that comes with it. I think it's important to remember that with osteoarthritis, it is a normal aging process, and but there is ways in which fortunately, people can learn to definitely live with the problems that definitely occur as one gets older. So many times, because of the discomfort that's associated with osteoarthritis, people tend to sit around and become even more immobile. And we know immobility can lead to some of the problems that I talked about on that worksheet and activity I just got done discussing. Atelectasis, pneumonia, decreased GI motility, paralytic ileus, decreased tissue perfusion causing patients to be more at risk for skin breakdown and pressure ulcers. Not only do people suffer as they get older for sometimes any age group, but some of the common problems that we do see with mobility are, back pain. People that have chronic back pain tend to kind of sit around and kind of reduce what they do because of the severity of the pain. Fractures, people with MS, as I said, osteoarthritis, Parkinson's disease, and some of the spinal cord injuries. And many conditions can limit mobility. When people have a lot of pain, they tend to sit around and not move around. Fatigue, any type of respiratory disorder or cardiovascular disorder, some of the nervous system disorders, musculoskeletal problems, and may need some type of physical or occupational therapist to kind of get them moving again. But just remember too, osteoarthritis is a normal part of aging due to the wear and tear on the joints, okay? And as I said before, the most frequent areas for this to occur is the knees, the hips, the hands, and even sometimes the spine.